Today with Matthew Massaro, the Program Director of Oncology at Northwestern Medicine and the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. Matthew, thank you so much for joining us today.
Thank you very much for having me. Happy to be here.
As background, Northwestern Medicine is a health system headquartered in Chicago, Illinois, with 2,700 inpatient beds and 11,000 providers across 12 hospitals and other ancillary facilities. So, Matthew, thank you for joining us today. I understand we'll be speaking about throughput and capacity within the outpatient oncology setting. I'd love you to kick us off and provide some background into what you're up to and what you're looking to do.
Yeah. Well, thank you for the opportunity again. So my role and scope within Northwestern Medicine is oversight of all of our outpatient operations in oncology, specifically as it relates to our breast programs, gyn-onc, thoracic medical oncology, and benign hematology. And as far as how data intersects my life, it's pretty much on a daily basis and primarily focused on strategies that we have we implement growth or changes to our operations, whether it's aligning to new regulatory governances and abiding by those, or whether it's preparing for a future where we're giving care in a different physical setting or expanding upon our physical footprint of setting that we deliver care in. In all of those instances, data is very vital to the decisions that we make, both in forecasting future state, but also reacting to current state and adjusting as need be.
Yeah, and I understand that on a few different metrics, you work through financials. You mentioned staff productivity and patient volumes. Within that, you kind of break it out into labs and infusions and visits. Can you talk about how you are parsing out your different data sources and how you're able to look at them, present them, and analyze them in a meaningful way?
Yeah, there's a variety of different sources that we can pull data from in our system. We have data warehouses that exist, some that are directly embedded within our EMR system, and then some that exist outside of the EMR system, but are able to tap in and pull information out. And really the gamut of anything that we can think of as far as data can be helpful to us. Some of the data, depending on how granular we get, can be a little trickier to pull, a little more exhaustive because we want to make sure that what we're getting is valid, is true. We'll use data in terms of our patient volumes, in terms of different diagnoses that we treat, medications that we give. Infusion is a big area for us in oncology. So understanding the volume of patients who necessitate the variety of different medications that we give in the infusion space, and also correlating that to how long do these infusions take? Is this an infusion that's 30 to 45 minutes, or is this an infusion that's 2 to 5 hours? And then understanding the quantifying those volumes gives us a sense of what capacity we have in our operations, also aligning with our staffing models and how many individuals we need on certain teams and what types of roles. Nursing is a big one, of course, and looking at patient hours per nurse. So it's a pretty wide spectrum of data that we look at, and it's a little bit more finite, but a spectrum of sources for the data, where we're pulling those sources, and putting that all together. Yeah.
So, Matthew, once you can quantify the volumes, for example, figuring out how long an infusion is taking, how do you take action? What's kind of intervention can follow understanding how long an infusion takes? If it actually takes about 40 minutes and you had expected it would take 50 minutes, are you able to add an additional patient each day? Are you able to add more staffing? Just walk us through how exactly, once you see what your KPIs are and you define how long an infusion might take, then how does that affect operations and allow you to increase throughput and capacity?
Sure. It certainly depends on the lens of which we're looking through and why we're looking at the data. What is the problem that we're looking to solve to? What are we trying to understand about ourselves? So for example, with infusion, as we continue to grow, we have certain areas where Recent renovations and expansion projects have happened where we build out the capacity so that we have it, and then we look at, okay, how much, if we have a chair or two that we don't utilize throughout certain days of the week, if we were to open that chair, how do we make sure that as we bring in more appointments, if we add more appointments and patients to be seen, how do we ensure that we're not going to overload what we have for capacity? So we'll look at the average of in a given area, what is the percentage of the patient population that receives X, Y, and Z treatments, and then looking at the length of time that those treatments make. So it's all about forecasting for us to understand what is that future state going to be. Let's go ahead and expand. Let's add a couple more chairs. Now, when we do that, what's that going to look like in the clinic for the physicians? How many more sessions would we open? How many more slots on a given day would we open? And that's kind of, we're piecing those two things together to ensure that we have a stable environment.
So in order to forecast those future states, I understand you've built methods and models of calculating staffing and capacity needs. Can you speak about how those models have been constructed?
Yeah, it's so in some of the areas where we more recently constructed some models, it's really on the clinic side. So it's outside of the infusion space. So we have a model for navigation, for new patient navigation. We use nurse navigators to help connect with new patients who are newly diagnosed, and they call our centers, and within 24 hours they're on the phone with a nurse navigator, an embedded ally within our practice who provides upfront education. Because sometimes they might get their diagnosis, they call our facilities, and if their appointment is a few days or a week out, leading up to that time, we want to be sure that we're able to connect with the patient, meet them where they're at, and give them some support and some education so that when they have that first appointment in the exam room, it is a very efficient and effective visit. And so that involves getting the patient ready for it, as well as our clinical practice teams. So how we modeled that, to your question, how we built, quantified the capacity. We look at, for new patient navigation, we look at how many new appointments are we completing per week. So if the idea is we want to get on the phone and have interactions, at least a 60-minute call with every new patient before they even touch down in the clinic, we need to understand how many new patients are coming in per week and how long do they exist in navigation, meaning how long is it from the first point of contact to when they first see the physician. That period of time is easy to quantify because we understand all those metrics. Beyond that, there's a little bit of work that needs to be done to get deeper into the granular, like a time study, where we'll sit with our teams and quantify how much work is being done on each patient. They get off the phone. We understand that it's a telemedicine appointment. It's easy to quantify that that's a 40-minute call or a 60-minute call. But beyond that, does the patient reach back out over that next week? What are they reaching out about? Are there records that need to be gotten from the administrative team? Do they call back with symptoms that have come up that are necessitating further phone calls? So we do time studies where we'll sit in with our teams and quantify how many extra minutes beyond the initial call is every individual patient having the nurse be accountable toward, so that we can take that. If every single patient before they have their first appointment requires, what we find is about 120 minutes, 2 hours of time for the nurse navigator. What we do is then multiply that by the amount of new patients that we see every week, and that gives us a sense of how much work is to be done in every week. For a nurse navigator, how many minutes, how many hours in a week are they actively navigating, not going to a nurse meeting, not going to an education session, not meeting with their managers, not doing these other ancillary, but actively navigating our patients. And when we look at our model to say, well, how much do we need? We use these metrics. So it's a few different sources of metrics and how we put them together to understand what's the workload. If we're going to say,
Matthew, are you and your team actively building your own new de novo process measures, Or are these things that you're lifting from the National Quality Forum or from the American Medical Association or other kind of associations that standardize metrics? Or are you developing your own measures?
It's a little bit of both. It's almost like sourcing different recipes and figuring out what are the ingredients that kind of work for our area. There are certainly standards. Nurse navigation isn't something new that we've developed, and the idea of a nurse navigator connecting with a patient prior to their care isn't this new novel concept that exists only in our area. But the way we quantify and leverage it is unique to us. So how we come up with our calculations is the part that I would say is specific and unique and homegrown where we are. But the
Mhm.
concept of what we're trying to deliver is more of a kind of a best practice and I would say nationally recognized standard of practice.
I see. You mentioned that uh, you alluded to the topic of data integrity. You mentioned that you want to ensure that your data sources for these measures are valid and true. Can you
Yeah.
delve into how you're solving for how to create accessible data and reliable data?
Sure. Yeah, that's a very good question. So a lot of it, what I've found is how accurate the data is from the system that's pulling it is often dependent on the users and how they're interacting with the platform that the data is being pulled from. So, for example, uh, as practices exist for a while in the same EMR system,
Hmm.
there'll be different codes that mean the same thing. Let's take a new patient appointment. Over time, as practices evolve, let's say they move physically from one space to another, which is not uncommon. That happens a lot, especially here in Chicago, where I'm at, where we have a finite amount of space and we're always retinkering existing space and moving it. When that happens, over time, there might be 3 different new patient appointments that exist, and they're coded differently, but they mean the same thing. They might be worded slightly differently, or they use a different code. And so some schedulers might come in and schedule a new patient appointment under one particular code, same
Hmm.
slot as any other new patient would use. Whereas other schedulers happen to pick a different code that means the same thing to the templates and getting scheduled in. But when you go on the back end and you pull the data and you ask the
Hmm.
data and you filter down the search criteria of what they're pulling, you need to make sure that all different visit types are being accounted for. And if there's 3 different types of new visits, you need to make sure all 3 are being accounted for. What we do on the back end then is work with our teams to standardize and say, we're going to go with one. We know that some of you use this one, some use this one. We're going to define it, winnow it down to one existing. We're going to remove the other ones from the system. And then we're just going to have the one. So when we pull the data, we know it's true. Let's say if I'm the one pulling the data and I'm no longer in my position and somebody else steps into this position, they're likely not going to have that deep-rooted context that, oh yeah, let
Hmm.
me pull up all of those visit types that correlate with the new appointment. Let me make sure I'm accounting for all of those. So we try and winnow that down, but I scrutinize the data. We have a couple different databases here, and I like to pull the same information from both of them to make sure, are they telling me the same thing?
So, Matthew, I understand from what you just said that a lot of your solutions to data integrity are governing standards, meaning that you're going to say at Northwestern, though there may be 3 codes for doing X, we're going to eliminate 2 of those codes, that there's only one to simplify data analytics on the back end. I'm wondering if there are any technological challenges to normalizing, aggregating, and deduplicating data in order to ensure that you have reliable data when you're trying to develop your own process metrics.
Yeah, there's a few. When you're in a system as large as we are, you might locally determine that how the system is set up, the data analytics system, the data pull system, how it's set up might need to be modified to suit what we locally within our disease group need. However,
Hmm.
if we want to make a change, one of the tricky things is if this change is embedded within the system, within the data warehouse system, is that going to then create a ripple effect and impact other areas in the way that they're set up? Is the change that we're making not possible to be made just for our team? And is it,
Hmm.
if that gets retooled, is that going to change it for everyone?
Hmm.
So that can be something that we always that could be a roadblock and something we always want to be mindful for. The other is there's constantly new systems that are being developed. And as a new platform comes to fruition, if it looks promising and we believe in it, say locally, but it doesn't exist yet in our system because the information in the health medical records are so secured. In order to get a new system to have access to our medical record system, say like a data system to be able to plug into it, we got to make sure that everything's vetted. If we're going to have a new vendor, so to speak, it's a little more difficult to just kind of get that set up because we're such a large organization.
So, Matthew, a lot of our listeners are, I think a lot of what you're saying will resonate with them. Many of them are actively migrating to the cloud. I believe this is something that Northwestern Medicine has also begun doing. And many of them are involved in active merger and acquisitions activity. I'm wondering, as we kind of approach the end of this podcast episode, just a few more questions, but can you delve into the implications of migrating to the cloud or the implications of acquiring other practices, other hospitals, other entities on data reliability? How do you handle those data issues that arise from cloud migrations and M&A activity in order to ensure that your calculations are based on accurate data when you're calculating those metrics?
Yeah, I mean, the integrity of the accuracy, if you're going to be pulling in data and posting it to say this is what that number is, whatever it is, and you're going to be migrating that to the cloud. I think before it moves to the cloud, there needs to be kind of a team centered around scrutinizing that data to make sure it's accurate. Because once it moves to the cloud, then the assumption is it's going to be there. It's going to be there for a while. It's going to be accessible to people from different avenues, and they'll want to believe that it's true. So I think it's really important to just make sure that everything is scrutinized before it migrates over to the cloud. As far as the cloud, I think there's a lot of cybersecurity is, obviously very important, so that when that information goes into the cloud, one, it can't just be viewed by anyone, but just as importantly, it can't be manipulated. Once it's there, it should stay there. But that's in my experiences, I think healthcare has been, as far as the technology of data and sourcing data and quantifying it, healthcare has been a difficult sector to stay up to date and stay current with what the most advanced height of data analytics is. And I think that has to do with, largely has to do with how secure the information needs to be.
Yeah. So
yeah.
As we approach the end of this episode, I'd like to pose this final question to you. You've been working for quite some time. You're the program director of oncology, and you've been working on throughput and capacity within the outpatient oncology setting. You've been working on developing these different measures, building models, calculating staffing and capacity needs. What advice would you give either to yourself a few years ago, as you were earlier in the process of developing and managing these models and measures, or to a listener who hasn't yet begun to really go down this path? What advice would you give?
I would say as best as you can, work to standardize how you're organizing your data. So what I do is I'll pull information, but then I like to store a lot of it in my secured files that I have, say, in my drive. And it's important that I'm consistent with how I present the data to myself, and to do that consistently over time, and making sure that there's a system for it. Sometimes I can get lost in it and I swim in it, and then I reinvent how I present this data to myself, or I reinvent how I analyze it. And I think staying consistent with what your approach is and how you wrap your mind around it is very important. Sometimes you don't look at data, certain data, as frequently as others. So let's say there's data that I might pull once or twice a year. It's really important that I can go back to the last time I pulled that data and look at, okay, this is how I organized it. Here's the pieces that when I pulled the report that I parsed out. I took these columns out because we don't need them. They're not as relevant. They don't move the needle in our decision making. And then keeping everything consistent and organized. I think an organized file system is massively important for data. And how do you label your files, and how do you go back and know right away when you're looking into a folder, okay, that's what that was, that's that time period, that's what that was telling me. Early on, I would just kind of label things a lot very similarly, and then I'd open up a file, and over time, over a couple of years, it would just be this massive list, and I'm clicking in 3 different Excel documents, 4 different Excel documents before I actually find the one that I needed. And my head is swimming in all of these numbers and all of these cells and columns. So I'd say like your own organization system, figure that out, define it rigidly, and stick with it.
It may not be sexy, but in the pursuit of profit, vis-a-vis improved throughput and capacity in the outpatient oncology setting at Northwestern Medicine, it sounds like a efficient and standardized method of organizing data is the best path forward. So, Matthew, I'd like to thank you for joining us today.
Thank you, Jordan. Thank you so much for having me.
And for our listeners, this has been Matthew Massaro, the Program Director of Oncology at Northwestern Medicine and the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. Thank you, Matthew.
Thank you. Have a good rest of your day.
Okay, all done.